We work in a cellular therapy service, and what that means essentially is that we are taking immune cells from within the patients and we're sort of reprogramming them or repurposing them.
CAR T-cell therapy is a really highly specialized cancer treatment that acts like a living drug. We use the patient's own genetically modified immune cells. We insert a CAR gene into these cells so that they can then go and find and destroy cancer cells. The first thing is that we need to collect the patient T cells to make CARs from. And T cells are a type of white blood cell that fights infection. We collect these from the patient bloodstream through a process called apheresis, which basically looks a bit like blood donation. The second step is we send these immune T cells off to the laboratory where they undergo a reprogramming step. Scientists essentially insert a new gene into the immune T cells to make them express a new protein that they wouldn't otherwise make, that's called a chimeric antigen receptor, or a CAR for short. And these CARs are designed to recognize specific targets on cancer cells so that they can bind to those targets and kill the cancer cells. Now, we need millions of these cells to infuse to each individual patient. So, of course, when we make the CARs, we grow them up to these huge high numbers in the laboratory. And once we've got the appropriate dose, we then freeze them down in readiness for the patient to come into hospital. The hospital piece for the patient starts with some chemotherapy treatment to begin with. And the chemotherapy is designed to create space in the immune system so that when we infuse the CAR T cells, that they have room to grow, and they can grow in the bloodstream, they multiply, they make copies of themselves, and they can form part of the patient's immune system for months and years after the infusion.
So that is the beauty of this therapy, is that it enables us to reprogram the immune system to see and fight cancer cells.
The CAR T-cell service really requires the input of, a breadth of specialty across our unit. We have, our admin team that take the referrals, we have our excellent CNSs, we have our clinical fellows, our consultants. On the medical side, we have the nurses looking after these patients on the ward. To make the service run, we also need our pharmacists, we need our apheresis team, our stem cell laboratory. We have an excellent prehabilitation service here at UCLH run by our CAR-T physiotherapist. We have an excellent CAR-T dietitian who also is looking at optimizing the nutritional status of our CAR-T patients. When the patients are on the ward, we rely on every service to support them throughout the pathway, so the occupational therapists, the ITU doctors. The average patient coming through our unit with, for example, NHS CAR T-cell treatment, they have a diagnosis of large B-cell lymphoma. They will be referred by their local team who will be assessing their fitness for treatment and eligibility, and then get in touch with us. And they come up and see our lymphoma doctors, our disease-specific experts here at UCLH. We have an MDT group where we sit down once a week and we look at the patient's biopsy results, their radiology, blood results, and we put together a picture of suitability for CAR T-cell treatment. So the CAR-T pathway runs for roughly 6 weeks for the average patient. So patients will come to the lymphoma clinic initially if they have a diagnosis of large B-cell lymphoma. Then they will be hopefully approved by the CAR-T panel, and then come to the CAR-T clinic where we will discuss their upcoming treatment in detail. So the T-cell harvest needs to take place after the CAR-T clinic visit, and then it takes about 23 days for the cells to be delivered at UCLH, and this will depend. It can range from 17 to 23 days. And in that time frame, our priority is to make sure that patients remain as well as possible. And usually we will request that the patients receive bridging therapy via their local teams or sometimes at UCLH. So bridging therapy is also known as holding therapy, and this is the treatment that we give to patients after T-cell harvest and before they come in for their CAR T-cell treatment. The majority of patients here at UCLH will receive some form of bridging therapy, probably about 90%, usually chemotherapy, or we also have some bridging clinical trials the patients can access. Sometimes, if patients have a single site or very isolated disease, we will consider giving them radiotherapy during that time. And the purpose of bridging therapy is really to stabilize disease, and this is important because patients with lower disease burden tend to be fitter for treatment. They tend to have better outcomes, both in terms of efficacy and toxicity.
We perform various procedures using these machines, one of which would be stem cell or T-cell harvest. So what happens is when we connect a patient to the machine, we take blood out of one arm. It goes through the machine, and using a centrifuge here, it separates out all the different components within the blood. We then isolate the part that we want, for example, the T cells, and then we take them out into a separate bag, and the rest of the blood is then returned to the patient. So when someone comes to the unit, we take a blood test in the morning to check their hemoglobin levels. If necessary, we can do other tests. Then once we know that, we will set them up to attach them to the machine. We would either do it through a peripheral cannula in either arm, or the veins are not the best, we could use a vas cath, which is a line that is using the femoral vein for the procedure. The procedure, normally 1 day. The procedure is done while the patient's in the beds. There's very few side effects other than just being attached to a machine for 4 or 5 hours. You can eat and drink as normal, and the main side effect would be what we call citrate toxicity, and that is where the anticoagulant lowers the calcium levels, and that can be through tingling in the fingers, any peripheries, a strange vibration, or any nausea, and that's easily controlled with some calcium tablets. The needles are removed at the end of the day, and there should be no side effects afterwards. You can go home and go about your daily business. If you have the vas cath, the line in the groin, that will add an extra hour or so to the day. We need to take a blood test at the end of the procedure to ensure that the platelets are still above 50. Once we know that, we take the line out while you're on the unit. It just is very simple, takes a few minutes. However, we do need you then to lie flat for a good half hour to make sure there's no bleeding. Obviously, being the femoral vein, we want to make sure that you're safe to leave. So that adds, as I said, maybe about an hour to the day. But then again, you can go home.
I'm Stuart Ings. I'm the laboratory director, and I'm also the designated individual for the transplant program here at UCLH. This here is where we store all of our cells for all of our patients being treated at UCH. They are stored at ultra-low temperatures between -140 and -196 degrees C. Initially, we will receive stem cell harvests or CAR-T products from the apheresis department. They come here, we will test them, and we then package them, and either we will cryopreserve those cells or we will package them and send them off for a courier. We will also receive the final products for CAR-T cells. They will arrive in a shipper that you can see behind me, and we will make sure that we have received the correct cells for the correct patients, check all the necessary paperwork, and we will store them again in vapor phase nitrogen at -196 degrees centigrade. The Wolfson Cellular Therapy unit has 9 staff in total. I'm the director, and we also have a laboratory manager. We have 2 senior scientists and 5 biomedical scientists who do most of the work in the laboratories. The transplantation program at UCLH is one of the largest in Europe and is also the largest CAR-T program in Europe. In this room, in these freezers, we currently hold approximately 3,000 bags of patients' cells.
Ambulatory care is part of the inpatient cancer service but located in the outpatient setting. Eligible patients receive their treatment with us during the day and stay in the hotel afterwards instead of occupying a hospital bed. We do chemotherapy, stem cell transplant, and CAR-T for both licensed and unlicensed products. The hotel is about 3 to 4 minute walk. The patient can easily access the inpatient care when they become unwell, even during out of hours, by calling the ambulatory care mobile. CAR-T admissions are well planned and carefully scheduled since we are limited to administering 2 CAR-T infusions per day at present. Leukodepletion starts on the same day patient is admitted in the ambulatory care. The patient does not necessarily need a companion to stay in the hotel during leukodepletion. CAR T cells are administered at the patient's bedside by the ambulatory care trained nurse. Patients are reminded of the preparations they need to make and what to expect on day 0 prior to the day of the infusion. On day 0 of CAR T infusion, the patient will be transferred to the ward for 24-hour monitoring for the next 14 days. The inpatient team will decide if patient will require further ambulatory care stay after 2 weeks or will be discharged home. So we do the nurse assessment, so we do the observations, blood tests, check the medications, and the whole well-being of the patient. It is nurse-led service, so we don't usually involve the doctor when patients come every day. However, if there is any concerns, then we escalate it to the doctor and we ask the patient to stay until the doctor reviewed them.
We have one of the largest haematology services in Europe. So we have nearly 100 beds dedicated to haematology patients here. We actively encourage people to get out and about. We have a roof garden, we have a shop and a cafe just downstairs. The physical exercise that's important to patients while they're an inpatient is also supported by a physiotherapy team here. We have a dietetic service, an occupational therapy service, and a number of other services to help support your treatment and care here at UCLH.
So again, if we think about what a CAR T cell is, it's an inflammatory cell, and these are the cells that normally fight viruses. So how do you feel when you've got a viral infection? Often you've got a fever. You might feel sort of tired, and you might feel just generally unwell. That's certainly something that we see with CAR T cell therapy, because when we infuse the cells, these are cells that are fighting cancer in the same way that they fight viral infections. We do sometimes see patients with quite high fevers, and they can be unwell with that, and we call that cytokine release syndrome. And sometimes the patients get an irritation of the brain, so they can get symptoms of, we call it neurotoxicity, but it can sometimes be headaches and occasionally visual disturbances and sometimes speech disturbances, which are all transient, but they are all part of this inflammatory process that's driven by the CAR T cell therapy. Now, the good news is that we are extremely experienced in managing these side effects. They are very common. And so we have a very good inpatient team who can monitor for the emergence of these complications and treat them very early so that they can be managed well on the ward.
So CAR T is obviously a very effective treatment, but is associated with some neurological syndromes, some neurotoxic syndromes. And the most common and important of these is immune effector cell-associated neurotoxicity syndrome, or ICANS. ICANS happens usually about 5 days after CAR T is infused, and it can present in lots of different ways. So the mainstay of management is steroids. Sometimes in very, very mild ICANS, it's possible to take a conservative approach and to just watch and wait, and they may resolve by themselves. But anything more than that, we give steroids. We sometimes give another immunosuppressive drug called anakinra. And then other measures involve supportive measures, which may often need to happen in an intensive care setting.
So people need to stay in hospital at UCLH for at least 14 days after CAR T cell therapy. Following CAR T cell therapy, we do a PET scan at 1 month and 3 months after the treatment to see how effective it's been. Something we do is shared care, and we recognise that lots of people travel long distances to come to UCLH for CAR T cell therapy, and we try to do as much as possible as close to people's home as possible. And this can include reviews with the medical team at the local hospital, blood tests, treatments. We liaise very closely and coordinate care with the referring centre, and we do what we can to avoid lots of travel for hospital appointments. Something else we think about is how we can prevent infection following CAR T cell therapy, and we give people some preventative prophylactic antibiotics for at least 12 months after CAR T cell therapy. And then when we see people at 1 year following CAR T, we do some extra blood tests to assess how well their immune system's recovered, and we also recommend that people have a full schedule of revaccination of the vaccines that they'll have had during childhood.
As a CAR T clinical nurse specialist, I am here to guide patients through one of the most complex and life-changing treatments they'll ever face. My role is to be their constant, offering expert care, clear communication, and emotional support from referral to point of recovery.
care I received was excellent throughout. I had a particularly nice nurse who looked after me and was very caring. I later found out that I was her first CAR-T patient, so whether that helped or not, I don't know, but I have the feeling that she was probably very good with all her patients. And everybody who dealt with me was very kind to me and my family.
The care I had, I thought, was excellent. And actually, it was extremely impressive, really, because there were so many activities required in preparation for the transplant that I didn't realise at the outset. But there were so many different things I had to do in terms of tests and procedures to prepare for that. And then when I look back on it, everything occurred so promptly. It all joined together so seamlessly. It was like from one event to the next event to the next event without any pause. And I think the main reason for that was my clinical nurse specialist, because she must have been working really hard in the background, making sure that all those appointments were organised for me in the shortest possible time. And that was really quite impressive, because I've worked in a big organisation. I know that when you try and organise lots of events close to each other with different departments, that's a lot of work. So I'm very grateful to all of her efforts.
The UCLH cell therapy trials opened in 2016 with just one trial open for diffuse large B-cell lymphoma. And we now have trials open for B-cell leukemias, B-cell lymphomas, myeloma, lupus, MS, sarcoma, liver and lung cancers. In clinical trials, new cell therapy products are used, or cell therapy products that have already been used are compared against standard therapies. This can offer patients who have limited treatment options available an opportunity to access cell therapy. Patients receiving treatment as part of a clinical trial still have access to all of the usual supportive services, including a specialist trial CNS.
Here at UCLH, we work closely with University College London and the clinician scientists there to run clinical trials using the homegrown cell therapy products that they develop. We've been lucky enough to start seeing these go from early phase studies into bigger studies, and hopefully these will become available outside of clinical trials in the future.
And so that's really the essence of CAR T-cell therapy, and it's really transformed our experience of patients with relapsed cancers of the immune system, such as B-cell leukemia and B-cell lymphoma. And of course, we're testing it for all sorts of other types of diseases, such as autoimmunity and solid cancers. So there's plenty of developments happening in the CAR T-cell world for patients right now.
We've got the hospital on one side of the street, and then we've got the research labs on the other side of the street. So it makes translating our findings and developing clinical studies really very straightforward. We've also got a manufacturing facility, so we make the CAR T cells here on site as well. So we've got all the pieces of the puzzle to create a very functional research program. So the future is bright for CAR T research.